what we're trying to do today is go through the journey with dementia and talk really from the start to finish. And if we run out of time, we may not quite get to the very end. What we'd like to do is to interact with everyone. So basically, as we go through this, you don't want to sit here and listen to me for an hour yabbering on, and then you've got somebody else talking and then somebody else talking. We really want people to ask questions as we go along. So if we cover things, and you'll see that most of our slides are pretty general. So if you've got any questions around what we're talking that we're not covering, please just ask, and then we can talk about it and as we go along. Nathan and I we haven't talked with the other two presenters yet. We didn't get the opportunity, but I'm certainly not standing up here as a world expert on the latest research on Alzheimer's disease, and I don't think any of our speakers are taking that line. We've been asked to talk here as clinicians who have a lot of experience in managing people with dementia, and my experience is now sort of 25 years of doing this and mostly running in community services. So I've had a lot of experience with managing people with dementia, but I'm certainly, if you're going to ask me some question about the latest research on the Thai protein, I may not have the answer for you. So the start of the journey is often before it starts with dementia. And a question that I get asked a lot, and I'd imagine most general practitioners will get asked this, and most people who deal with people with dementia, is the anxious family members saying, oh my God, am I going to get this as well? What can I do about it? So that's a very common question, and it's a common thing, sometimes not even asked, but that's actually what everyone's thinking. And so just start a little bit on that. Basically, when you look at the latest research in dementia, and I'm saying I'm not an expert on it, but I certainly have been following it, the idea that there's going to be a big impact drug to be given to people with dementia is pretty much getting abandoned. I mean, if you look at the latest research, they're still doing trials on various drugs, but nobody's got anything which looks that great. Increasingly, the research is looking at finding biomarkers, so some sort of a blood test or something you can do to somebody to identify somebody who may be developing dementia before they got it, and then to try and do some interventions to, to do some intervention to either prevent it or slow it or delay it. So there's quite a lot of research going on that line. Firstly, when you think about a biomarker, so you do a blood test, well, partly if anyone lives long enough, they're probably going to get dementia. So if you all live to 110, we're probably all going to have significant memory problems. So everyone's got a risk for this. So what you're wanting to find is a biomarker which will identify people who are going to get it early, which is actually even more difficult. So they're doing tests to indicate people might get dementia, but like just about everyone's positive. They're looking at genetics and all sorts of things. Once you have been identified with this, then you've got to do a trial on a drug which you give to somebody when they're 40 years old, and they take it for the next 40 years with the hope that it's going to prevent the onset of Alzheimer's disease, which is a pretty long shot, because I don't know how many people would be keen to take some drug for 40 years without really knowing whether it's working or not. So it sounds a good notion, but it's got flaws to it. And interestingly, the drugs that they are trialling are GSK inhibitors, which the most commonly available GSK inhibitor in New Zealand is lithium carbonate, which is too toxic. It's got too narrow a therapeutic window to be used for these kind of treatments, to give somebody, at the age of 40 to take lithium for the next 40 years in the hope that it'll prevent dementia. But it's those kind of drugs, and they're looking at drugs which have that sort of action but are safer and easier to take. There are a number of risk factors that we know for people to develop dementia. We know that if a person has a family member with Alzheimer's disease, there is potentially a greater risk. So if my mother has Alzheimer's disease at the age of 60, my risk of developing Alzheimer's disease at the age of 60 is about doubled. If my mother has Alzheimer's disease at around the age of 75, my risk of having Alzheimer's disease at the age of 75 is about the same as everyone else's, so your risk isn't that increased. So early onset dementia is a risk factor for developing dementia in the next generation. You've got to look at the statistics. Everyone's risk of having Alzheimer's disease at 60 is around 1 to 2%. If it's doubled, it's 3 to 4%. So you've got a 96% chance of not getting it. And that's the thing that families need to understand. If they are, as they should be, concerned about the onset of Alzheimer's disease, there's quite a lot of evidence to show that there are strategies to reduce the risk. And that's probably not to reduce the risk of getting Alzheimer's disease, but to delay the onset of Alzheimer's disease. That's pretty much what we're talking about. So the things that your GP's been telling you all your life is true. And if you want to prevent your heart attack, you do the same things to prevent your Alzheimer's disease. So blood pressure, smoking, too much alcohol, obesity, diabetes, high cholesterol, all of these have been shown to increase the risk of developing Alzheimer's disease and developing dementia. So if your family member's sitting there thinking, what can I, am I going to get this? You say, well, you probably will if you live long enough. But if, you've got a risk of developing it earlier in your life, what can I do about it? Well, there are things they can do about it. And I have this conversation a lot. So by reducing your vascular risk, you reduce your risk of getting Alzheimer's disease. I don't really think that's prevention. I think it's really delaying the onset of this illness. Got any questions about that? So getting to, I guess, the meat of the topic, well, actually going back one again. I thought about putting a nice juicy definition of dementia on the slides and everyone could take it home. But I mean, there's lots of these things, and we're all health professionals here and probably have an idea of dementia, so I'm not going to give you a definition because there's lots of them. But basically, what dementia is brain failure. We see people with heart failure and renal failure. Dementia is brain failure. The brain's not working right. It's packing up. It's damaged in some way. All the diagnoses, the Alzheimer's disease, the vascular dementia, the Parkinson's dementia, are all causes of brain failure. And so that's pretty much what dementia is. Now, we only call it dementia if it's actually affecting a person's ability to function. So we accept that people can be a little bit forgetful, and that as they get older, they get a little bit forgetful, or maybe they just stumble on words sometimes, or they don't make quite as sharp decisions as they used to. But that doesn't necessarily mean they've got dementia. You have dementia if you're progressively getting worse and it's affecting your ability to function. And so these are the people we're talking about today. And we're not going to get, well, I'm not going to get hugely specific on the various diagnostic types. So, yeah, this is the part of the presentation we're really here for. So basically, and I'm trying to really look at this at a primary care point of view. The people come in and basically saying, what's wrong with her, doc? Underneath that is that we know that most people have been struggling away with this problem for a couple of years before they go and talk to their doctor about it. And most people actually know there's something wrong, and they kind of know what it is. So although we sit there and sometimes we'll do a basic memory test and say, well, there's nothing wrong with her, everyone knows that you got it wrong because they actually know there's something going wrong. Families, and we've been trying to promote this as much as possible, and this is generally what is promoted, is that early diagnosis of dementia. And the Alzheimer's Society has got a new campaign coming out, and part of it is about early diagnosis. Because families want it and patients want it. There's lots and lots of research all over the world showing that that is highly valued. And the people who don't really value it are the health professionals, because we kind of feel a bit uncomfortable to say, well, actually, yeah, you've got Alzheimer's disease and your brain's going to pack up and, the future doesn't look too good. And so we're reluctant to say this to people. Doctors and nurses and everybody else are not good at giving bad news. And so we kind of hedge around it, and we do some memory tests and say, oh, it's not that bad, and try and avoid getting there. So there's a reluctance among health professionals to diagnose dementia. I get constantly asked by doctors and psychologists and other people saying, has this person got dementia? When it's so totally obvious that they do. But they're just not comfortable about actually saying, you got dementia, and then deal with it. So there is a disconnect here between what people want and what people need as families and what we offer as health professionals. So when they come and ask us that, they probably have a pretty good idea what's going on. So the first question we have as clinicians is, well, is this dementia? And I know there's a question came through about which cognitive test to use, and we will get to that. But basically, dementia is a clinical history diagnosis. No cognitive test diagnoses dementia. So what you need is to sit down with the patient and the family, and it takes time, which is frustrating because they're all so busy. But basically, you need to spend time talking to the patient. In the very early stages, most patients will give you a pretty good history. As it gets more progressive, they probably don't know what's going on, so they won't give you a good history. So it's really important to get information from other people. It's virtually impossible, I'd say, to be clearly sure of dementia until it's very advanced, unless you've got history from somebody else. So almost always these people get brought in by the husband or the son or the daughter, and you can get that history, and they'll say, well, she hasn't been quite right for a couple of years, but just the last 6 months things have been getting a whole lot worse. Yeah, is this Alzheimer's disease, doc? And so you take a history, and pretty much if you've got a history of somebody who's getting progressively worse over the last 2 years, and it's been a lot worse over the last 6 months since they had the hip replacement surgery, and they now can't organise their finances, and they set fire to pots in the kitchen, and they're saying, geez, I'm forgetful, doc. That's dementia, pretty much. Of course, there's all sorts of other things we've got to think about. So you can't see these things. So there's a whole lot of differentials, and part of what we're thinking with dementia is when you see somebody who's presenting and sitting there in front of you with what you think is dementia, you've got to think about these. Damn. Gee. Put it up here. No, it's me. It's not the machine. Can't blame the machine. So you've got to think about other things that could be causing this person to be with this history of mental deterioration, who looks a whole lot more confused. What other possibilities? And the reason for thinking about other possibilities is basically, is there anything you do to reverse this or stop this getting worse? That's what your thinking is. So there's all of these things, and I will kind of go through them. I mean, obviously delirium, we all know about delirium. Somehow in the last couple of years, psychiatrists have become the experts in delirium. When I started in medicine, the physicians were the experts in delirium. And everyone's kind of uncomfortable with it, I think, because we see so much of it, particularly in the hospitals. But I mean in general practice, in rest homes, as people, they get a chest infection and they're completely confused and they're falling over and nobody knows what to do. And as people get older, they're more likely to get it. So if you've got a history of somebody who's actually been kind of slowly getting worse, but just in a general pattern going like this, and suddenly, bang, they're a whole lot worse just this last week, the first thing you want to think about is their physical state. So they might have an infection, all sorts of horrible things could happen to them. So, and that's probably delirium, and it may be delirium on top of dementia. But when you're making decisions, delirium is something you can reverse. And with delirium, we're really talking about physical illnesses. Now, obviously, there are some physical illnesses which can present with confusion, progressive memory loss. So, physical illnesses, a person who, for example, has chronic obstructive respiratory disease, is getting increasingly hypoxic, those people get confused. They get chronically confused. They can present with what looks like dementia. And to some extent, it probably is to some degree, because they're getting slow, chronic hypoxic brain damage. It is something you can do something about, maybe, if they stopped smoking, of course, or oxygen, or other things that might, you might take some of the fluid off their lung with a diuretic, and they might be less hypoxic, and they may function better. So there's a whole range of physical conditions. We're talking about medication. Lots of medications, and we'll get to that when we do pharmacological things, but lots of medications can aggravate confusion. So if you've got somebody who's chronically confused, who's taking 30 milligrams of diazepam a day, the first thing you want to do is try and cut that back to see whether that makes any difference. So people with Alzheimer's disease, people taking diazepam 30 milligrams a day can get Alzheimer's disease, but it can be an aggravating factor, which if you reduce the dose might improve their function, might slow the deterioration or slow it down. Long-standing deficits, we get a lot of people with intellectual disabilities or who've been marginally functioning from an intellectual point of view for many years, and then suddenly as they're getting older, they think they've got Alzheimer's disease. Chronic mental illnesses, people with schizophrenia, as they get older, they develop cognitive deficits. That's part of the disease. Exactly when that turns into dementia or Alzheimer's disease, nobody knows, don't ask me, because nobody's got the answer to that. But there comes a point with most chronic schizophrenics is that they do develop a dementia. Depression, we treat a lot of people with antidepressants. People can present, who are depressed, can present with cognitive impairment. It's part of the condition of depression. Treating depression tends to improve cognition. I've not seen anyone who's been cured of their Alzheimer's disease by treating depression, but it can certainly make a big difference to their ability to function. So it is worth thinking about those kinds of things. At a practical point of view, these kind of reversible factors, these things, we've got to be sensible, because you could do like 1 million tests on everybody, and if you've got an 85-year-old person who's mildly confused in a rest home, you don't want to probably chase an Alzheimer's disease diagnosis too hard, because it's probably not going to make any difference to anyone. If you've got a 65-year-old who presents with what looks like dementia, then you're going to be much, much more aggressive in trying to identify reversible factors and look at the differential diagnosis. So, the cognitive testing, and I'm happy to try and answer any questions if I don't. So, bottom line is the most important line. It's not the score. It's the clinical history you've got from this person. Your cognitive test is really to kind of confirm or get a baseline for what you actually already know. So your diagnosis is based on the history, and it's very unusual that a cognitive test like a MMSE or a MOCA or something like that's going to change your clinical diagnosis. There's lots of tests, and one of the questions we had was, which one do we use? What's the best one? Well, nobody knows. That's the short answer. We worry about the MMSE because somebody bought it and has patented it. Now, I've had a bit more sort of insight into this, is apparently, and you can turn the recording off now, if you use a form which says MMSE and you do it, then you are breaking the patent. If you, like I've used the MMSE for 20 years, I just do it without even looking at it, I'm not breaking the patent. I was relieved to know. Yes.
I would first ask a question about which test is best, but which test is most appropriate. But one of the frustrating things about all these tests is they're very hearing orientated, and yet we're dealing with a population which, in the most part, have hearing impairment.
Yeah.
And my question was, is there anything on the horizon that will help with that population? Because whilst they're not essential, they are a tool that we use to assess where they're deficient, and it's very equivocal when you're asking questions and you know that people they either, like the mocker, give up because it's so long and they can't concentrate that long, or you're asking them questions and you know that they're not hearing it properly, or they think they're hearing because they want to please you but they're not. And so you then look at the result and think, well, how valid was that? I don't know. And that's the problem with a lot of these tests, is you're dealing with a population basically deaf.
Yeah, we got a little gadget we carry around with us when we do visits. There's a little headphone and a little speaker thing. And yeah, you get much better results when people use that, because they can actually hear, even if they've got hearing aids, or most of the people you go and do a home visit, they can't find their hearing aid, or the battery's flat, or it's going beep, you can hear it in the room. So we carry a little hearing device around with us quite a lot. All of these tests are affected by all sorts of things. So MMSE, if you've got dysphasia, you get a bad score. So, if you don't have good language function, you can't name, you can't find the word for November, so you're going to get that wrong, even though you know it's November, you just can't find the word and express it. People who are highly anxious do badly on tests. So you can go to the house. I mean, it's really interesting. We get people go to the GPs and do an MMSE at the doctor's surgery, and they get terrible results. We go and do it at home when we visit them, and they get a much better result. It's because they're less anxious, and they know where they are. And so, because that's 5 points for knowing where you are. So every one of these tests has limitations. And I guess what I'm saying is if you've got somebody who you don't think is actually able to get the test or do the test, well, firstly, that's diagnostic in itself. But also, I don't necessarily go through the whole MMSE for everybody. I mean, if somebody's unable to do it or they're too anxious, I might just ask a couple of questions of the things I'm particularly interested in, like, for example, a memory test, and make sure that they get that one test. As I said, the score isn't actually... The score isn't that important. It's an indication. It's to give you some indication of where the deficits are. So, for example, you get 27 out of 30 on the MMSE, which is a normal score, and you can have quite significant dementia. That's 0 out of 3 for the memory test. And so, on its own, the score doesn't actually mean a lot. And you can get a score of like 15 out of 30 on MMSE if you've got a mild dysphasia, but in other respects you're actually functioning quite well. So all of these tests have limitations. I don't have the answer. There is not, as far as I'm aware, a new test that's going to be better. They've done some research in New Zealand here, trying to work out the right scores for these tests for the New Zealand population. They all are similar. They all have their limitations, and they all are kind of equally good and equally bad. Addenbrookes takes quite a long time. MMSE and MOCA take about the same sort of time. MOCA tests frontal lobe function a little bit better than the MMSE. But I think you've got to understand what your test's testing, and you've got to think through. So on the MMSE, if you think this person's got frontal lobe impairment, well, the MMSE is not going to test any of that really. So you want to ask some other questions. So you might do some questions like for verbal fluency, or get them to do the trail making test or something like that, which sounds very complicated, but you can get an app on your iPad, trail making test, scores it for you, age, norm, everything. So, some of these tests are actually quite easy to do, although most people with frontal lobe impairment just can't even understand the iPad, so that's a limitation. So I don't have the answer for you, but nobody does. And I think the way to see these tests is that these are tests that are confirmatory, that give you an indication about what you've been told. So this family or this patient's told you, I'm forgetful. So you're going to ask some questions to test forgetfulness. And sometimes, the 3-word test in the MMSE is just a 3-word test in the MMSE. You might ask them about other things, about what's been going on in their lives, what's they've been following the news. This person there watches the news every night. He's absolutely fanatical rugby supporter. You ask them some questions about the rugby. See if they know anything about it. They might remember things that they care about a whole lot better than they remember your 3 words on a test. And again, it's giving you an indication of where this person's at. It's not telling you this is a diagnosis of dementia, but it's giving you some idea. Does that answer your question? Not really. I mean, it's a limitation of these tests.
Yeah, I just find it's a limitation for quite a large percentage of the population you're testing. So, I just wondered if there's anything new in the framework for...
From a practical point of view, the most useful thing we've found is having that little headphone thing with a gadget on there, and you just go to the house and they can tolerate it for 5 minutes. Most people don't like it in a conversation because it picks up all sorts of rubbish noise. But if you just sit in there doing a 5-minute test with somebody, they can put on, tolerate it, and do it quite well. And your point is, you actually see people's scores get much, much better when you do that, because hearing is a factor. Anyone else want to ask anything about these tests?
Can I just ask a test? I've come across a guy who, to talk with him conversationally, you would never pick up that he had dementia. But his family have given this history of extremely poor judgment. He's been ripped off, locked into some kind of financial thing. He has no ability to judge it. Is having huge amounts of money going out because he's locked into this, and appears to have this kind of area of his brain that's just not functioning judgment-wise. Now, we're presuming it's dementia. How do you pick that up on testing?
Well, these kind of tests, you probably wouldn't pick it up. I mean, you could make this guy do some sort of test of trail making or verbal fluency or similarities or animals, all these kind of tests we do, but those are very basic tests and they probably won't pick up the subtleties of mild frontal lobe impairment, which is probably what that guy's got. I mean, in our team we would get our psychologists to do a more detailed neuropsychological assessment. That's probably the gold standard test for that sort of thing. And most of the sort of simple 5, 10, 15-minute tests that we do are not likely to pick that up. Again, probably the clinical history is really telling you what you know. I mean, they say, you know, the best indicator of frontal lobe impairment is life. And if people are doing those sorts of things, that's probably an indication the frontal lobes aren't working, and for some reason. I mean, you might have a brain tumour sitting there. There could be a whole lot of reasons. But you're probably right. So you want to do a test to confirm that. And when you're trying to convince him that he's got to hand over his property to somebody else, it's quite nice to have objective information. And that's why a neuropsych test would be very useful in that sort of situation. So the investigations, and we're all good at this, actually. There's all the blood tests. I mean, by the time I get to see somebody, everyone's had the blood tests serially over the last 5 years, so it's really good. So you do want to look at indicators of other disease, and it's quite useful to... certain things do affect cognitive function. People who are anemic, iron deficient, B12 deficient, thyroid deficient, all of those things can affect cognitive functioning, and if you remedy those things, it actually can improve cognitive functioning. The other part of that is that you're looking for, is there some other disease to explain why this person's deteriorating? So if this person's anemic, it's not to say, oh, we'll give them some iron and they'll be right. You want to ask the questions, why is that person anemic? Are they losing blood? Do they have a tumour somewhere? So some of the blood tests are just, you're looking at indicators of other disease, and some of the blood tests you're looking at an explanation for why this person is more confused and whether you can reverse that. I have to say, in all my years in psychogeriatrics, it's pretty disappointing, the results of, you know, the person's B12 deficient, you give them B12, nothing changes. You know, the person's iron deficient, you give them iron, nothing changes. The other thing about some of these tests, they're also an indication of person's nutrition. You know, your guy with frontal lobe impairment is probably not eating properly, and you might do blood tests and find that he's iron deficient and B12 deficient, and that's, again, another indicator of how this person's functioning. And if you improve his nutritional status, he actually might be healthier, and therefore he might be a bit better. So we do that. CAT scans, MRI scans, we're looking at what the brain looks like. The neuropsych testing, which we mentioned, is really how the brain works. And CAT scans, there's an argument each way. Some people say you should scan everyone with dementia. Other people say it's pretty much a waste of time, you shouldn't bother. We tend to scan people who are younger, who have some sort of unusual pattern. So your guy with the frontal lobe impairment, who in other respects seems to function pretty well, he's somebody you'd probably think of doing a CAT scan to see if there's any other disease. The younger they are, the more likely we are to scan them. So we see quite a lot of... In Hawke's Bay, we've got over 65 people with Alzheimer's disease under the age of 65. Those are just the ones we know. And virtually every one of those will be scanned pretty early on to see if there's any other condition to explain why this has happened. There's an argument, MRI scan versus CAT scan. MRI scans are better. They show you better, but you wait 6 months for one. CAT scan you get in about 3 weeks. So we CAT scan people because people want to get on and know what's going on. Most people, you'd identify whatever's going on with a CAT scan. In Hawke's Bay, we're pretty remiss on the ECG front. When you're thinking about treatments like donepezil, that can cause heart block, so it's quite a good idea to know the person's got heart block before you start them on donepezil. We don't routinely do ECGs in everybody, but some guidelines would say that if you're going to give somebody donepezil, you should do an ECG. EEGs, well, we do them occasionally. If you think somebody's got some sort of unusual seizure activity, they're not very helpful. That's my experience. And certainly, like in Hawke's Bay, we have a fairly basic EEG, so we don't get a particularly sophisticated one, and you really want the sophisticated ones when they stick leads up the nose and things like that to look at temporal lobe. activity. So we don't find that a very helpful thing. Again, your decision about what investigations you do also depends on the person's condition, where they're at, how advanced their dementia is, how old they are. So if we're seeing an 85-year-old person who's in otherwise good health, who's got some mild memory deterioration, we won't CAT scan those people. Is everyone okay with that? We're lucky in Hawke's Bay. We've got a neuropsychologist in our team. So,
how many of those in the 65s are mild memory?
probably a disproportionate number for the numbers of under 65s. A lot of the people we see who are under 65 have had brain trauma. That's probably the most common. Then also substance use, smoking would be probably the three big risk factors. And there is a genetic component. There's some people who's got a family history of early onset dementia. But most of the people we see have actually damaged their brains in some way. Rugby players, disproportionate number of rugby players. And in Hawke's Bay, orchard workers who are exposed to these chemicals.
Finding a lot of horse trainers.
Sorry?
Finding a lot of horse trainers.
Right. What chemicals are they using? Yeah. Well, yeah. So I think there are things, there's a lot of stuff we don't know about the brain and the toxic things that we're exposed to and how that affects the brain. And I've got a slide later on early onset dementia, but I think one of the problems with young onset dementia is that nobody's kind of owned it. Nobody's that interested in it. And so these people have just kind of rattled along and been fairly randomly assessed, and nobody's really looked at this group and looked at these trends like horse trainers or like orchard workers or, you know, whatever, rugby players. And they're only just starting to look at these things. But basically repeated head trauma is probably the biggest risk factor that we see, and smoking. Neuropsychological testing is the gold standard, really, for diagnosis, in my opinion. So if you're not sure, so we got people who, like your one there, who's kind of not typically demented. You think this is probably demented. Somebody's going to argue with it if you tell them that. A neuropsychological test is the gold standard test to resolve that. And I think to expect ourselves to be able to resolve all of these issues in our day-to-day practice is beyond what we're actually capable of doing. I don't think the psychiatrist's simple neuropsychological testing is enough to answer some of these questions. And people would say, well, we don't have a psychologist in our team. Well, you should. We're lucky in Hawke's Bay we do. I work in Gisborne as well, and we can get access to that, so even small places can get access to it, and it's worth paying for as part of your service. So, as I mentioned already, us as health professionals are generally quite reluctant to give bad news. I mean, we're kind of trained as healers, and we want to be nice, we want to be liked, so we don't really want to tell people, but what people want is the truth. And as the years go by, I must say I'm getting more and more kind of straight up with people and blunter with them, and you just tell them this is what it is. And that's actually what they want. And the feedback you get from that is that, thank goodness somebody's finally been straight with me. It's been going on for 2 years now. Jeez. Because as I said, you're telling people what they already know, most of them, and what they actually want to do. The reason they came to see us in the first place, is there anything we can do about this? They kind of know this person's losing their mind. It's been obvious to them for years. And they've been adapting to this all the way through. For years, they've been changing the way they do things. And Dad does all the cooking now because Mum burns pots. So what people really want to know is that. But we need to be clear in our minds what we're dealing with. And I think, you sit down and tell them exactly what it is, exactly how it is. And they all kind of know the prognosis because everyone's read it. People are so exposed to information. I mean, Scott very kindly suggested that only 20% or 20 of us in this room have been touched by dementia in our own families. I would say probably 80%. There's very few families now that haven't been experienced dementia in some ways. It's the world we live in. People are very informed. You've got the internet. People look it up. The sons and daughters are all in their 50s and they're very internet savvy and they know everything. But they need us to confirm it. That's what we do. And as I said, they need us to be straight and honest with them. And we need to be honest about the prognosis. And then what? Well, it's, one of the memory clinic model, the biggest criticism of the memory clinic model, I don't know, does anyone work in a centre with a memory clinic? Yep. So the biggest criticism of the memory clinic model is people go to the memory clinic and they get like assessed by all these experts, and then they kind of get spat out and said, well, you got dementia, you got Alzheimer's disease, go back to your GP and we'll refer you to the Alzheimer's Society, and that's kind of it. Now, I'm not saying your memory clinic's like that, of course, but certainly that's the big criticism of the super specialised model of diagnosing dementia. And really the real issue of this is, what do we do? So I put medical interventions right down the bottom, and we'll talk about that later. But that's really very low on the list. So, for example, I would not consider giving somebody donepezil, for example, until all of these other things have kind of been thought about. So if somebody's in a situation where it's intolerable and unmanageable, you're not going to give them a treatment that's going to stop them getting worse, because then they'll remain intolerable and unmanageable for another extra year, potentially. So you've got to make sure the right sort of environment is there, the right sort of supports. I think I got more on that. Yeah. Modifying the environment, all of these things. The person's got some activities, they know what's going on, they get information. So part of what we do in Hawke's Bay is that if somebody's got early dementia, one of our team will then go along later on, a couple of days later or a week later, and then talk to them some more about what's going on. Because when you sit there and you bombard, you say, oh, you got this CAT scan showed this, and this, you got Alzheimer's disease, it's terrible, Then there's a million questions they forgot to ask. So you want to give them the opportunity to ask them more questions. The Alzheimer's societies, some are better than others in this country. So we're lucky in Hawke's Bay. We've got 2 Alzheimer's societies, Napier, Hastings, 2 towns, and they're all run by health professionals. So there's a very high level of knowledge in the Alzheimer's Society. So you can go to the Alzheimer's Society and we can refer them, and they can get a lot of really useful information. So people can get access to information, support services, the carer struggling away. So before we think about medication, there's a whole lot of these things that need to be thought about. Environmental modification. Any occupational therapists in the room? Yeah. Occupational therapy is probably one of the key disciplines in old person's mental health. But for the plonkers like the rest of us, some of the decisions are quite simple. Environmental modification. She's burning pots. You could disconnect the oven and get meals brought in. There's the things you can do that actually immediately remove risk. Take the car away for goodness sake. We can't do that. Well, you have to, because she's going to kill somebody. So there's all these things that can potentially can actually change. We can make recommendations right off the top. We do not have to say, well, I'm going to refer you to an occupational therapist and she'll come see you in about 3 weeks' time. And you can actually do things straight away, which are quite practical. All those carpets, do you trip over when you go into the house? They're going to trip over when you're not there. And of course, all of these things. Now, some of these probably, so you can't see this. Each one of these is a lecture on their own, so don't know how much detail you want. Driving. Okay, the research on driving would show that anyone with any degree of dementia should never ever drive again. That's pretty much what the research shows. People with even the mildest dementia are about 10 times more likely to have a major accident than somebody who doesn't have dementia of the same age. Unfortunately, our law is quite sort of grey on that. So the law allows people to continue to drive. And so we're all in this dilemma of when do you stop driving. It's not if you stop driving, it's when you stop driving. So I usually kind of signal this right at the beginning, but you don't make a big deal of it when you're talking about, you've just been diagnosed with Alzheimer's disease. Oh, and you've got to stop driving forever. So you can introduce these things as you go along, unless there's an immediate issue with driving. But in most cases, in the early stages, it isn't an issue. We have access in every centre, I think, just about, of off-road driving assessment by an occupational therapist. Some people have to pay, some don't. In Hawke's Bay, you don't have to pay for the off-road, but if you pass, you've got to pay for the on-road. There's a debate and argument about that, the rightness or wrongness of that. That is the gold standard of driving assessment. Doctors and nurses and everyone else are not good judges of a person's actual ability to drive. But as I said, the science would say, you got dementia, you're at a greater risk of accidents. If the family's saying, hell, I won't let the grandkids in the car with Nana anymore, that person should not be driving. If that person's car's all scraped up and you walk into the driveway and the house and the side of the car's all munted, that person shouldn't be driving anymore. If the family is saying, geez, we're a bit worried about the driving, well, that person shouldn't be driving anymore. Now, exactly how you deal with that is very difficult because you don't want to destroy a person's life on one visit. So you need to work towards that. And as I said, I think these driving assessments are very good. It's a process which is objective, and it's got the gold standard assessment is available. So that's something we should defer to. And sometimes people pass those tests, and you think, oh my goodness, they shouldn't be driving, but they pass the test. We have to defer to the test. It's the gold standard. Do you have any questions about driving?
Just going to comment that when I came to New Zealand, I was quite surprised that the attitude to driving was more relaxed than the UK. And you see people with quite significant cognitive impairment and say, oh, I've been told I can only drive locally. So you can only kill local people.
Yeah. Only the kids at the kindy next door. It is. I think in California is if you've got a diagnosis of Alzheimer's disease, you've got to stop driving. And you've got to prove that you can drive. So you've got to go to the test and prove that you can drive before you're allowed to drive again. So, other nations. But I think most countries in the world are struggling with this. And I agree. I think we're a bit woolly here, and it is a bit scary. I was just driving the other day in Hawke's Bay. I was driving along the road, and on the off-ramp, up comes this little lady in her car going up the on-ramp, completely on the wrong side of the road. And, that happens all the time, and these people, really shouldn't be driving. Enduring power of attorney, I guess everyone knows about these. Everyone should have one, every age. We should all have one. All the elderly people should have one. It's a good idea. So we encourage people very early on. So if somebody's being diagnosed with dementia, we'll say, look, you've got to get an enduring power of attorney. And most people will go ahead and do it. It becomes more and more complicated as a person loses capacity. So once they lose the capacity to appoint an enduring power of attorney, it's a real problem. Because then you've got to go to court and get a welfare guardian or property guardian or something like that. So you need to go through that with the family and talk to them about that. Same with wills. And we're getting, it's an industry, I think. I could go privately and just do reports on wills and EPOAs, and I could have a full-time job because there's so much of it around. And I think lawyers have become quite nervous, and so they're more reluctant to change wills and enduring power of attorney without a mental assessment of their capacity, which is kind of potentially could completely clog up our entire health system doing this alone. We encourage people to take the world trip now. Don't wait for 2 years as you were planning originally. We see a lot of people who travel. I think one person that I've known in all the years I've done it got into a real strifey idiot, had a drink on the plane, and he got completely confused, and they stopped the plane and threw him off somewhere in Asia. And but of all the other people I've seen over like 20 years, nobody's really had major problems travelling. And again, I think people got to change their goals. If your travel plan is to, we're going to fly to London, we're going to get on the train, and we're going to go boom, 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 boom. Bad idea. If you're going to fly to London, your daughter's going to pick you up, they're going to take you to the flat for a few days, then you're going to go there for a few days, and that usually works out quite well. So talking to people about those kind of plans is quite important, actually. And I get asked that a lot. But also, as I said, if you're planning to go and visit the kids in Los Angeles, do it sooner rather than later, because things will get worse. That's the one thing we know about Alzheimer's or dementia generally. It's going to get worse. I'll leave Nathan to discuss the cultural aspects. I mean, it is an area that I think everyone struggles with, of every culture. I mean, the whole issue of Alzheimer's disease, you struggle with it within your own culture. And then when you're dealing with people from other cultures, it's even more complicated because we don't really understand it. It was interesting, an Indian family asked me to see them the other day, and really what they wanted was to know kind of how you Europeans do this. You know, are we on the right track? That's pretty much what they were asking. They were managing their mother beautifully, perfectly. But they needed a reference point because they were floundering themselves, and they wanted to kind of know how everyone else did it, because within their own culture, people didn't really talk about that. Our elderly people are very vulnerable to exploitation. Your guy who's squandering all his money is extremely vulnerable, and it is part of our responsibility to try and protect people from that. That's this one. That's the culprit. How we do that's very difficult. The PPPR Act is there specifically for that reason. And we tend to underutilise it. We tend to not like going to court and dealing with lawyers. I hate it. But it is something that we probably underdo when we see people who are getting fleeced. Protection of Personal Property and Rights Act. That's the act which has the EPOA in. So the enduring power of attorney is part of that act. But basically the Protection of Personal Property and Rights Act is legislation which is exactly that. So there's a process by which people can be protected. So for example, your guy who's squandering all his money, one option is to go to the court, make an application to the court to appoint somebody as a property guardian so that somebody else takes over the management of his property so he cannot squander his money. And the court can then appoint somebody who might be the son or daughter, it might be an independent person, the court's discretion. You have to demonstrate that this guy completely lacks the capacity to make those decisions. So that's why your neuropsychological test is necessary to prove that this guy's got significant frontal lobe impairment.
The interesting thing in this situation is that they're from another culture. And the sons, particularly the eldest son who has that, should have that role, because of the difference in their culture, extremely reluctant to take over any power of attorney.
Yep.
Because it's seen as disrespectful. So it's, a bit of a vicious circle. So the cultural aspects, they're pretty important in the whole deal, aren't they?
And the PPPR Act process stumbles around that. They struggle with that as well. But I think our role is, if you see this person is getting exploited and is vulnerable, I guess our role is we should be addressing it, and that is the legal process by which it can be addressed. It might be a relief to the family that the court steps in and says, well, actually, no, this is not okay that this guy's getting fleeced. The court is going to appoint a lawyer from their own culture or whatever, or another family member to actually make those decisions, or even the older son.
Who can initiate the PPR?
Anyone can make an application. Right. Now, part of the problem is the precedent of the way it's run in most centres is that theoretically the PPPR Act is somebody make an application to the court would then request a medical assessment or an opinion about this person's mental capacity, and then the court would make a decision. What tends to happen, most courts, certainly in Hawke's Bay, they're not interested in all this blimmin' waiting around, so they want the applicant to come up with a medical assessment as well, or capacity assessment. It doesn't have to be a medical one. A capacity assessment on day one. So you front up to the court with an application, anyone can do an application, and the opinion about the person's mental capacity. And sometimes people die of old age before the court actually gets to hear it. So, it's not always that efficient. And some courts are a whole lot more efficient than others, and Hawke's Bay is one of the slower ones. But it can be done under urgency. There is a process in the court that accepts urgent assessments, urgent decisions. So, for example, this guy is squandering all his money. There could be an urgent court order that somebody acts for him financially while the whole lot gets sorted out. So that thing is there. Hawke's Bay Court is not prepared to do that.
Taking that example, where the two senior men and the sons in the family who are very reluctant to undermine the mana of the father by taking away his financial control, who in that situation would trigger this court process?
Yeah, you could.
Right, okay.
I mean, the further away you are from what the family wants, the more tenuous your position is. So in most things, like the Mental Health Act, people are very reluctant to use the Mental Health Act if the family is strongly opposed to it. So like all of these things, if everyone's saying, no way in hell are you going to do that, you're getting out on a limb. But sometimes it's a big relief that somebody says, no, this is not okay, this is the process, and everyone just heaves a sigh of relief. Oh, thank goodness somebody's doing something. So, yeah. So anyone can do an application. In Hawke's Bay, it's usually the social workers, like in the hospital social workers, community social workers, often the people who drive the application.
It's so useful having a multidisciplinary team to help make that decision, and looking at it from various aspects from the therapist, because it is a really difficult, often very complex family situation where you're going to appoint a welfare guardian because there is nobody else suitable, and it's fraught with, it's quite stressful.
It is stressful, but I mean we do need to remember that the court is the one who appoints it's not us. And we fret about that. Who's going to do this? I don't know.
Because you're taking away someone's freedom, and so you have to think extremely carefully about that decision that you're making for that person.
Under the PPPR Act, for example, that guy, they could take away his access to his finances. But every other respect of his life, he'll still have capacity, or he'll still be autonomous. So, it's not necessarily all or nothing. And the other thing, the whole principle of the PPPR Act is that you do the least intervention. So in this guy's case, sorry to keep harping on about but basically they would manage his finances at a certain level. And that's all. That might be all that is allowed by the court to happen. So yes, it is taking his autonomy, but it's not like throwing him in jail and locking away the key. It's actually quite a lot less than that. I think the PPR Act does not get used as it should. When you read the Act, it looks wonderful as a fantastic thing to protect people. The way it actually is done in practice is kind of clunky and doesn't work quite like. There's delays in the court, people can't be bothered, the lawyers can't be bothered, it's not very lucrative work, so there's no real enthusiasm. So there's a whole lot of things that don't work very well in many areas in New Zealand. Advanced directives. We were discussing advanced directives yesterday in Hawke's Bay, and the reason that they don't really work very well is we wait till somebody's just about dying and then we say, oh, you've got to do an advanced directive, just so we've got an excuse not to treat you next time. But basically, advanced directives in dementia, it's a good idea to talk about these things pretty early on, because people can make decisions. People with mild dementia can make decisions. When they've got advanced dementia, they can't make decisions. And the other thing about people with advanced dementia is they're not really distressed, most of them. So they don't care. It's everyone else around them who's distressed. So to give them the opportunity to express what they want is quite good at this stage. Now, advanced directives at this point don't have a strong legal standing, so it's not like this person's written, there's no way in hell I'm ever going to rest home, that everyone is bound by that legally. But it does give everyone an indication of, of what that person would prefer. And that strongly influences people. You walk into the hospital when your mother has a stroke and you put the advanced directive in front of the doctors and say, look, we don't want you to do anything. They will not do anything, pretty much. People really respect it. So it is something, but the problem with advanced directives, I think, is that firstly we do them too late, and secondly we probably make it too complicated. It's become quite bureaucratic, and also a bit of a tick box now.
Sorry, again.
Yes.
Have you had, or are you using the advanced care planning tools? Or
Yes,
your area?
up to a point.
I was just thinking, particularly in dementia, like you say, the person's not worried at all, but at that point you get the opportunity before they, their capacity diminishes to tell you their choices and what's important to them.
Yes. So we are promoting that very actively. I've got to say it hasn't really kicked in yet, but in our day-to-day practice we're not seeing people with these. I mean, it's like most of us, I guess, if we look at it, in our business, I'd imagine most people say, please, please, please don't ever make me go into a rest home. I'd rather die. And yet, many of us will end up there. I think 25% of Americans die in rest homes. But I mean, to be able to express those kinds of things, if I get dementia and I'm starting to really deteriorate, don't give me life-saving treatments. Don't give me life-prolonging treatments. You know, for goodness sake. I do not want to end up like that. But our advanced directives really haven't got to that level of sophistication, I have to say. Certainly the ones I've seen.
But surely your EPOA for your health and wellbeing should know what the wishes are if you've done it early enough. So you wouldn't need both.
Well, the EPOA has no right to withhold any life-saving treatment. The EPOA has no right to, does not make those decisions.
But if the person is aware, would it have to be a written thing, like an advance directive as well? Because the EPOA should be aware of what the person's future wishes are.
It gets watered down, though, I have to say. You know, I personally think empowering people to express it themselves is what we should be doing, because I think we'll get a different spin on it. I mean, a lot of families who've watched their parents slowly deteriorate, and the daughter who's been lovingly caring for her mother all these years finds it really hard to say, look, she's got a chest infection, I don't want you to do anything, just let her die. Whereas that's probably what the patient wanted. When I get to this point, I get a severe chest infection, don't take me to hospital, don't put me on IVs, just let nature take its course. That's what most elderly people say to me. But that's not in any way incorporated into their... Yeah. It's a very difficult area. I think it's something that really needs to be developed better. And I can't say that we're the experts on it in Hawke's Bay. We certainly aren't very good at it yet. So I've kind of covered some of these things. There's lots of social supports available, some more than others. If you're in Gisborne, there's a lesser range. And if you're in Te Puia, there's even lesser range. And if you're in, Auckland, there's a different range. So it varies where you are. I think everyone will know about these things. I realise we've got 5 minutes now. You haven't started waving yet. No, We've talked about that. What can you do to try and stop this condition getting worse when you've got early dementia? So people go to the health shop, they buy hundreds of dollars worth of stuff. They've changed their diets. The evidence that changing your diet when you've got dementia makes any difference is just about zero. The evidence of taking fish oils when you've already got dementia or ginkgo or anything like that is just about zero. Antioxidants in your diet are good. We should all be eating them. The best source of antioxidants are fresh fruit and vegetables, whatever's in season. You don't have to go to the health shop and buy them. Eating heaps of vitamin C or something like that is probably not going to make any difference. So basically what we promote is basically a healthier diet if people are not eating a healthier diet. Physical activity, there's good evidence that physical activity protects the brain by improving the circulation to the brain. We encourage our people to be a lot more physically active if that's possible. And mental stimulation, we encourage mental activity. There's no evidence that one mental activity is better than another. They've done studies, knitting's really good, Sudoku, whatever it is, gardening, whatever. But being as mentally active as possible. In Hawke's Bay, we've got a cognitive stimulation therapy program, which is a specific treatment which is focused on mental activity, quite systematic mental activity. That's been shown to be as effective as any medical intervention in terms of maintaining and improving cognitive function. So those kind of things are important, and that's certainly what we encourage. You're really wanting to encourage people to actively do something about their condition rather than sit there and wait for a pill to kind of protect them, because as we'll hear later on, the pills aren't that great. Education's important. That's the next talk. So, has anyone got any questions? Cinnamon, yes. Well, everyone who listens to any kind of media will see every month or so there's a new thing. There's a lot of people who are getting a lot of research money to research Alzheimer's disease, and so they've got to come up with something. So there's all these drugs that are being given, and Scott, you'll hate to hear this, that etanercept is one of the front runners. $60,000 a year. So there's various treatments, and most of these haven't got past the mice. And, you know, there's people go all over the world. I've got patients who've gone off overseas, they've gone to Australia, they've enrolled in drug trials and sorts of things. It's almost always ended up in tears. Coconut oil is a popular one at the moment. Again, I think the tide has turned on coconut oil. It's got more bad fats than butter. But I mean, there's all sorts of things being promoted. Again, the science is pretty weak on virtually everything. So to be a buzzkill. So.
Do you know much about BDNF or brain-derived neurosimilarities factor?
Yeah.
And there's apparently some things that can actually activate help and help with this. Do you know much about that?
I went to a very interesting lecture on that just recently, which most of it went over my head. Yes, that is an area of research. I think it's a long way from turning into anything clinical.
Apparently there's some supplements that work on that.
I don't know.
Yeah, just from pharmacology. Just a slightly wide question. We've been talking about people's journeys with dementia, and just taking a slightly wide perspective in your psychogeriatric practice and potentially, I guess, oversight of rest homes, etc. Do you actually have issues sometimes with what I would call false positives? That is, patients whereby kind of stories get changed and embellished somewhat, and they arrive at a rest home, say a stage 2 rest home, with or even possibly never care, not obviously stage 3 dementia care, with the label of dementia, and then it kind of takes on its own kind of momentum without necessarily actually having been formally diagnosed, and that may not be the case. Is that something you would see or not really?
Oh, yeah. I mean, I think most people and most practitioners are very capable, and so it's unusual. I think people with chronic mental illnesses sometimes end up labelled as dementia in order to access residential care. So people with chronic schizophrenia or chronic severe depression, anxiety, personality disorders sometimes end up with a label just in order to be able to access funding for residential care. I think that does happen. And in a way, these people probably need residential care, but they don't really have dementia. So it's kind of two wrongs making a right. The most common ones we see are people with alcohol. They end up in the hospital, confused. They've been drinking alcohol for 5 years in unhealthy quantities. They've got quite significant cognitive impairment. They get assessed quite appropriately as being incapable. They get put into a rest home. 3 months without alcohol, they're so much better that they can function back in the community. And so we've seen people, there was that case that everyone goes on about, that I think was in Auckland somewhere, that some woman was 3 years in a rest home after being admitted after alcohol, and then she, for the last 2.5 years, there'd been nothing much wrong with her. So alcohol is probably the main one that we see. And we've, the way I see it is there's no one-way tickets in this business, and people can be recategorised. Sometimes people lose their home, sell it, go into residential care, then there's no way back. And then people have got to fudge around to try and find some justification for funding it. But I think that's not that common. People are pretty careful. I think the issue is people are more reluctant to go down those tracks than enthusiastic about going down those tracks. Yeah. As I said, the alcohol ones, we see it 3 or 4 times a year. People get admitted to residential care, on the face of it, quite appropriately, who don't need it within a few months. And then they go back home, of course, and they start drinking again.